a postdoc fellow, that's right, from 2012 to 2015 at the University of Michigan, and also research investigator there in the Department of Internal Medicine following that from 2016 to 2019. She's currently an adjunct faculty at Emory University and leads a genomics consulting firm from Denver, Colorado, where she works on various projects with the Colorado Department of Public Health, the Georgia Department of Public Health, and of course, Children's National. Full disclosure, she is a consultant on my grant on newborn screening. So without further ado, I'll hand it over to Dr. Gornick, and I will go on mute. If I leave, it's because I have to change the Bubble Guppies channel. I will be back shortly.
Thank you for having me. Can everyone hear me okay? Okay. I don't know why I asked that, because I can see Annie, so you can, yeah. You can nod if I'm, or like do that if I'm too loud or you can't hear me. Well, thank you for having me today. As Beth mentioned, I'm a geneticist and statistician by training. It was during my time at the University of Michigan where I was, let's say, exposed to qualitative methods. I like to think of myself now as more just a methods person in general. And I think what I've learned through my work is it's more about what the best method is, not for the question that you're trying to answer, not stats or is the answer to everything or qualitative analysis is. I think it really has to do with what your goal is, what you're trying to accomplish, and hopefully you'll see that today. So it is odd that somebody who has a degree in statistics is using qualitative methods, but I really came to appreciate them for answering, especially this type of question. Yeah, so I will get started. If anyone has any questions, I think I can see the chat, or you can.
Yeah, we can monitor the chat. Annie and I monitor the chat. Do you want us to interrupt you, or?
Sure, whatever, yeah, I'm totally fine with being interrupted.
And then we'll leave time at the end for Q&A.
Sounds good. Okay, so I'm going to talk today about a newborn screening project that I did in Iowa. And it was one of, I think, the best uses of this deliberative method. We called it a deliberative community engagement. I'll talk about what actually this method is a little bit later, but it has a lot of different names. Some people call it citizen jury, some people call it deliberative democracy. So there's a lot of names to it, but it's really all about it sort of has a shared set of principles that I'll go into a little bit more detail about. And I'll talk about the Iowa newborn screening project in more detail too. But what I wanted to first start with, let's see if I can advance the screen. Let's see. There we go. Is giving a little bit of background on what is newborn screening, just so we have, we're all on the same page. And I think importantly for this project, it's also, we need to talk about what it isn't, because I think that is, maybe not for this audience, but I think for the citizens that we were, well, I think most people, not just citizens in Iowa, but I think the general public may or may not be familiar with what newborn screening is or what it is not. So what is newborn screening? So newborn screening is a medical screen. It's similar to something like a colonoscopy or a mammography. So it can tell you that you might be at risk for having a condition. Like you have an increased chance of having a condition, but it can only tell you if you actually have the medical condition after further testing. So in the example of a colonoscopy can tell you that you have a polyp, but it may not actually, you have to have a biopsy to confirm that it actually is colon cancer, for example. So it is conceptually similar to that. It is a population-based screen. So by that I mean all individuals of a certain population. In this case, or the example that I'm going to give today, the Iowa newborns are screened. So I think it is arguably one of the most successful public health initiatives that we have in this country. Maybe the only one, I don't know. And even though it's been a huge success in the United States, there are still a lot of issues that I will talk about today. So it's a public health initiative, and it's also a system of care. And by that I mean it's not just a lab test. You know, the parents, healthcare providers, hospitals, labs, the pediatricians afterwards, newborn screening staff, they all play a part to make sure the whole system works in the best interest of the newborn or the baby in this case. So it really is a coordination of an entire system of care. It's not just a single time point. And I'm not going to talk too much about that part today. You'll see when I talk about the Iowa project, we kind of had it was a 2-day event, and we kind of had two different focuses. One was more on the screening part and whether or not we should screen for conditions. And then we really did talk the second day all about the system of care and how to improve the communication process. But that's another talk for another day. So if you need somebody to come back and speak again, you can, I'll come back and give you the second half of the talk. Okay, so what newborn screening is not. It is not a diagnostic test. And I think this is something that may be obvious to some of us, but it is very nuanced for people that are not used to screening tests and knowing the difference between a screen and a diagnostic test. So it will not tell us whether or not a baby has a condition for sure. And I think that's very confusing for parents, especially when you just had a baby. It is not a fortune cookie. So by that I mean, if there is a late onset type of condition, which there are some examples of that in newborn screening panels, it cannot tell us when, if, or how bad the symptoms of the condition might be. And I think that's also very difficult for a lot of parents, everyone involved, pediatricians as well, that it cannot tell us the details. It just says that, you know, you're at a higher risk. We don't know how bad it's going to be, when, if, all of those sorts of things. Okay, so newborn screening is not just the heel stick that most people probably think of when they think of newborn screening that happens. There's actually 3 parts to it. There's the hearing screening. So most states, or all states, have hearing screening programs. They also have where they check the amount of oxygen in the baby's blood. There's and then there's also the actual heel stick that most of us are thinking of. So it's the newborn blood spot screening program. So there's 3 parts of it. The blood test is really what we're going to focus on today. The heel stick, and it's generally performed when a baby is about 24 to 48 hours old. And I think, and you know, Beth is probably the expert, so she can answer that. Or there may be other experts in the room. I think that's true in all states. I think most of it's done in the hospital. Obviously, if you have a home birth, there's different situations, but I'll talk about this a little bit more in detail in the next couple slides. But usually it's done within the first day or 2. Okay, so newborn screening in the US. So I'm going to start with the US and then talk about the states individually. And really, I'm just going to focus on Iowa because, as you will see if you don't already know, each state is different. And yeah, so that adds to a lot of this stuff here. Okay, so the screening in the United States. So most of this information that I'm presenting here is taken from Baby's First Test, which is actually a really nice resource if anyone is interested in learning a little bit more about newborn screening, or if you want to refer. It's meant to be for providers, but also for family members and parents. So it's a nice resource. So in the US, conditions newborns are screened for differ for each state, as I mentioned. But there are national recommendations to guide and support states in their development of their programs. And there is a committee that works to set these national guidelines called the Advisory Committee on Heritable Diseases in Newborns and Children, which is a terribly long name and even worse, an acronym, but you know, that's what it's called. So they meet regularly to discuss proposals from parent advocates, various organizations and experts in order to keep newborn screening up to date. In addition to that, the U.S. Secretary of the Secretary of the U.S. Department of Health and Human Services reviews the committee's meetings and recommendations. The timing is important because certain conditions can go undetected if blood sample is drawn before 24 hours. So this is something that is reviewed. The meetings are held regularly, but often criteria and things like that are reviewed on a case-by-case basis. The committee and the secretary of the U.S. Department of Health and Human Services work together to create this recommendation called the RUSP. So you'll hear me talk about that a little bit later. So that's the Recommended Uniform Screening Panel, or RUSP. And that's a list of conditions. And I think currently there's 35 core conditions and 26 secondary conditions, which the committee recommends every baby should be screened for. So you can already see how this is starting to get like confusing, and there's layers here. So there's 35 core conditions, and then there's sort of this 26 secondary, they call it. And my understanding is that that all states, I think most states screen for those 35 core conditions, and then the other 26 secondary, it varies drastically, and some have way more than 26, as I will touch on, thanks to some of our advances in genetic technology. Okay, so the committee recommends every baby should be screened for these conditions. It's important to note that the RUSP recommendation is not a law. It's not mandatory. So again, this is where it sort of kind of gets sticky quickly. It's not mandatory, but it's meant to serve as a guide for the states. After consulting the RUSP, each state chooses which conditions it'll include in the newborn screening program, in their program. So I'm going to talk a little bit about Iowa and how it works. And I think really Iowa is just, I mean, yeah, it's the state that I worked with in this case, but I think it's a good example of how every state is different and similar in some ways. So it's a good case to work through, I think, and give you a good sense of how it works, but know that it is different in every single state. Okay, so in Iowa, after a baby's born, a health provider discusses the screening process with the baby's parent. Now, I did not have I have never lived in Iowa, so I did not have any of my children in Iowa, but I did have children in the state of Michigan, and I don't remember this process happening. I mean, I know it did, but my point is that you're a little bit overwhelmed. And in Michigan, unlike Iowa, Michigan, you actually have to consent. And I don't think in Iowa you actually have to sign a consent. So, you know, again, this varies by state. I had to actually sign something in Michigan, and I don't really remember it happening. I mean, maybe I did.
Yeah. You had to sign the biobank.
Yes, yes. So Michigan is one
they
of the—
wanted you to not conflict, but clearly it's not clear.
Correct, yes. And I think, you know, this came up a lot during the public deliberation that we had. This is because, for a lot of reasons, but mainly because you just had a baby and so you're a little bit busy or, you know, tired. So, but in Iowa, the idea is that a healthcare provider discusses the screening process with the baby's parents. We're not going to talk about that too much today, but like I said, we did a whole other day on process, and that was discussed a lot. But okay, so a baby's heel stick, which is just a poke to give blood, it literally is a stick and you prick the heel. It happens about 24 to 48 hours after birth. The blood's collected on filter paper, and this is also often referred to or called the dried blood spot test, so you might have heard that terminology used. The filter paper is sent to the state laboratory. Laboratory tests are performed to see if the baby has increased risk for about 50 different conditions in the state of Iowa. So if you have a negative screen, that means the newborn is at no increased risk of these conditions, or there was none found. So no further up is required, and parents can ask for the results of the child's health from the child's healthcare provider. So the results, the positive or negative screen results, go to the pediatrician. And if you have a positive screen, the parents also are contacted. So I'll talk about that in a second. But I also, so both of my children had negative screens. I never, I mean, you know, never talked about it with the pediatrician. It never came up, or that I remember, I should say, to be fair. There's a lot of things I don't remember. So, you know, that, I think that's interesting. A lot of parents at this Iowa deliberation were also felt like they should have a discussion even if the tests are, the screen is negative. Okay, so if there is a positive screen, you sort of go to, can I use the pointer? Yeah, this thing here. Oh, that's kind of fun. Or is that making people nauseous? I won't do that, okay. So the positive screen, okay. Pediatricians and parents are notified as soon as possible, usually within 2 days. A diagnostic or clinical test might be required. So after the positive screen, it's either deemed to be a false positive, so the follow-up test is normal, or a true positive, which means the diagnostic test confirms the condition, and the baby is referred to a specialist, usually a medical geneticist at that point. Okay, so again, I use Iowa as the case example to walk through, but each state is a little bit different. And I actually have no idea how it works in Washington, D.C. or Maryland, but that it can be another discussion some other time. Or maybe Beth has already talked about that. Okay, so what's the problem here? You know, we have this national guideline, we have this committee that meets, and the Secretary of Health and Human Services reviews everything, so it should be great. One of the biggest problems, as I have alluded to, or blatantly made clear, is that state newborn screening programs differ. So the states differ in the procedures and the implementation of the newborn screening and how it's done. Again, there's guidelines, the RUSP is there, but there's a lot of differences in each state on interpreting and how they apply these recommendations and this panel. So as I mentioned, I think most states do the 34 or 35 core conditions, but the secondary conditions vary quite a bit. And some states do many, many, many more. This many, many more, so in addition to these 35 core conditions and the 26 secondary conditions that are recommended, genome scale technology is now being applied in clinical medicine, and along with it has come a lot of its complex issues. So newborn screening is not protected from this. It has taken on all of these complex issues. But I will say before this is problematic. And what I'm gonna talk about today is related to the Iowa newborn screening project, is really how the state wants to decide with public input. So they'd like to have more public input into which of the secondary plus conditions are added to the panel. So this is sort of, you know, leading up to what this project was about. I do want to say, despite this, these, you know, challenges, overall, the newborn screening program has a great track record, and it really is a very successful public health initiative. Although the states differ in their procedures for how the blood spots get collected and transported from hospitals to state labs, the different methods they use, turnaround times, all these things differ in each state. It has been largely successful, so I want to make sure that's clear. Okay, so deliberative community engagement. So I'm going to talk about this method, this deliberative method, and it's the approach that we took here I often refer to it as deliberative democracy. In the Iowa project, we called it deliberative community engagement. It's also citizen jury or some other terms that have been used to refer to this. Okay, so what is this and why did we use it here? So as I just mentioned, the state of Iowa was interested in incorporating the members of the public's feedback into the process of newborn screening and which conditions are added to the newborn screening panel in that state. This is an oversimplification, but my understanding of how it was working, and I think is probably pretty common in most states, is the legislatures essentially make the decisions. So there's sort of meetings held and members of the public are invited to come in and sort of give their opinion on what should happen. My understanding is that this is mostly dominated by parents and family members and advocacy groups for newborn screening or for specific conditions that people and would like to be added to the panels or screened in their state. And one thing to think about and this was something that Iowa was thinking about, is this is a public health initiative that is paid for by the citizens of Iowa. And so your tax dollars are going to this. And they felt like everybody is affected in that sense. And they should have some say in what conditions are being added or screened, not just the people that, the advocacy groups that are would like their conditions added to the panel. This is my interpretation, so I should want to make that caveat. I'm not speaking for the state of Iowa or anyone on this project, but that was my sort of interpretation being involved in this project, is that they really like to give members, the public in the state of Iowa, a voice. So that's how I got involved. I've done some other work with deliberative methods, specifically in genome sequencing, and I'm currently doing a project in breast cancer in the state of Georgia with Emory University, applying this method as well. And yeah, so I think this is a really great method for incorporating public feedback. Okay, so as I said in the beginning, after working and receiving some training and working with qualitative researchers, I think from what I've learned is one of the most important things here, and when deciding what methods to use, are what are the questions you're interested in and what is the best method to accomplish what you're trying to do. So in this case, the state of Iowa was really interested in how can we elicit opinions from the Iowans, the citizens of the state, and bring it to policymakers. And that is really what deliberative democracy, or these deliberative methods, come out of public policy. So they've sort of come out from that realm. And that's where the term citizen jury came from. So they really are juries, jury-like, where you have to actually do some voting on policy. What's nice about this is it's a method for obtaining informed and considered views from members of the public. So this is not just we give people a survey and say, what do you think about this? Or do you want to have this condition added to the newborn screening panel? Because most people would say, sure. I mean, if you asked me, do you want to have your genome sequenced? Or if you go, maybe not if you asked me, because I would say no, but if you ask somebody off the street, would you like to know all of your genetic information? I mean, I think it's reasonable to think people's gut response would be like, sure, I don't know, sounds good. So this method is designed to provide people with information, allow them to consider the different viewpoints, and then make a decision based on that. What's nice about this method too, as you'll see, is we actually make people vote and elicit, so this is sort of where the jury part comes in, where they actually have to make a decision. People do not like this part. They don't like to have to stake a claim here, but this is what we force them to do in this method. So I will talk about that a little bit more in a second. Okay, so there's 3 components to the deliberative methods. The first is providing some level of education. So usually this entails written materials. We make videos for people to look ahead of time. We also have what we called expert panelists. So we had, in this case, we had people from the state of Iowa who were involved in the newborn screening program come and talk to the citizens. We had people, an individual who was affected by one of the conditions that we were talking about, and his family come and speak. We had somebody from the state of Iowa come and talk about like how they make the decision, how to make decisions, and set new policy at the state. We had a pediatrician come in, we had a medical geneticist come in. So it's a lot of education and the idea here is to provide sort of a balanced, unbiased types of information on both sides of the issue. So to help foster debate. So this allows participants to have some level of information so they can actually engage in really thoughtful debate, not just sort of going with what their gut response is. So the third part of this, so the second part is engage. So this is something that I think is probably the most important part. We actually have at the University of Michigan, some of my colleagues have actually tested the 3 different components of deliberative methods to see which one is sort of the most important method or what has the biggest effect. And it's always been, what we have found is it's this engaging part. So it's peer deliberation. Education is great, and like making people vote and pick something is, important, but it's not engaging in discussion with experts or the panelists or, whoever. It's peer deliberation. So talking amongst your peers, other citizens that have different opinions than you, different backgrounds. And the idea here is that the aim of this approach is really to foster engaged citizenship, collaborative problem solving, and directly involve diverse members, diverse opinions from the public in the decision-making process. And that I think is obvious in the peer engagement part. Okay, so this slide, this is a newer one that I added. Recently I had a colleague tell me that, he referred to deliberative democracy planning a wedding. And I was like, that is exactly what this is like. And hopefully you'll get the sense, of the scale of this, but it really is like planning a wedding. You have to get, both like your in-laws involved here. You got to get make invitations, you got to make sure everyone's fed and happy and this sort of thing, like housed and all this sort of thing. So I thought that was just a really great metaphor for planning these events. But I do think these deliberative community events look like a genuine wedding. Okay, so this is an oversimplification of the process, but I think it's a nice way to sort of see where the key components are, the major time points. And where we get the different data sources from. I think that's another important part. So this is mainly qualitative, but we do some quantitative measurement here, mainly through some of the surveys. So the first large part of this process is recruiting participants. And this is actually this requires a lot of time and consideration. So you really this is something that when I have helped other groups plan these events, can be challenging and it's hard to accept at first, but I think it is actually really important. You want heated discussion amongst peers, because if everyone agrees when they're actually in their peer groups deliberating and talking about the different sides or viewpoints of these issues, you're not going to foster debate. So part of this is really you want to pick individuals that are representative of your target audience, in this case, the state of Iowa and citizens in Iowa, but also that are going to have different viewpoints because you really want to foster discussion. After participants are recruited, again, this is also very difficult because you need to pay people. People are giving up at least 2 solid days of time, usually on a weekend. It's a lot for people to travel. You have to house them, so it's a lot, and it's a lot to ask people to do. So that can be difficult. The first sort of data point is your baseline survey. So you kind of want to assess where everybody is before the deliberation, so before the education part happens. Usually we've done this before the actual event, but some people have done it just in the morning before like any of the expert panel presentations have occurred. The first part of the day is usually these educational sessions and presentations, followed by small group deliberations. So people are broken up into small groups, usually of 4 or 5. They discuss the different, we give them tasks. They have to actually discuss these different pros and cons and have some sort of task they have to do. And then we all meet together as a large group again, and we actually have to do voting. So we make everybody vote yes or no, and I'll show you some of that data in a few slides. And they have to do it in front of everybody. They have to like raise their hand. And so it's an interesting process. And then after the event, we survey everybody again and to see if there has been any sort of change in their from their baseline assessment. And then we also do a post-deliberative session. So this is usually a month or 2 months after, because as we know from survey research and social behavioral sciences, that people often revert back to sort of closer to the slide back towards their baseline after they go home and talk to family members and have, back to their normal lives. Okay, so I'm going to jump in to the Iowa example here. And so we called this, What Do You Think? A community discussion of the Iowa newborn screening program. And this was held a little over a year ago in Iowa, in Johnston, Iowa. I think it was about a half an hour outside of Des Moines. I can't remember now. I remember I flew into Des Moines, but that's about all I remember. So this is where we held the event, not in this barn. This is not where I held the event, but in Iowa. Yeah, okay, so I will start walking through some of the data so you can kind of see like what we found. So I know this slide is not great, it's a little bit blurry, but I had, excuse me, some issues with my PowerPoint last night, so I had to quickly redo this in Google Slides, and it's a little bit fuzzy, but I think you can still see the different points I'm trying to make. So this is actual data from the participants. We had, I think, 65 total, somewhere in that range. The majority of the participants were in their 20s and 30s. We tried to recruit a few individuals that were under 25 and individuals that were older, but we did want the majority of the participants to be sort of like in the childbearing years or also in the sort of post, like having small, or, teenage children, or having gone through this process a little bit. So that is the age breakdown. The racial breakdown is pretty, I think, aligned with the, we tried to have it be representative of the breakdown in the state of Iowa. We did try to over-recruit a little bit from minority populations in the state of Iowa to make sure that those voices were also in the room and heard. The other, so the sort of geography was pretty aligned to what the breakdown in the state of Iowa is. So there was about a third small cities, about a third of them were from rural and very remote parts of the state, and then some were from the larger cities. And education as well we had an overrepresentation of college graduate or professional degree. And we did try as much as we could to recruit high school graduate and some college or technical degree. So I think this is the only one that's probably not as representative as we would have liked it to be. But it's, I would say it's fair to say that it's probably easier for people that are have higher degrees and jobs, stable jobs that don't have to be working on the weekends. So we did this on the weekends. So a lot of the individuals in the state of Iowa, live in rural areas and farm and things like that. So the weekends are important time to them, so they could not attend. So that had some influence on our numbers. Okay. So this is not meant for you to read at all. This is just meant for you to see that we had 2 days here. Each one of these is this agenda, and it is jam-packed. So hopefully this gets you the sense of like why this is like planning a wedding. It is jam-packed. It is like every minute scheduled. We give them a lot to do. Like they are there to do serious work. I'd like to think that it ends up being really fun, and we do have like the evenings off, and we had stuff planned for them. Also like a wedding events for them, like a wine and cheese, or we didn't have that, but something like that. Whatever you do at weddings these days. But it's a long day, and there's a lot that they have to do. The other thing I wanted this to sort of represent is sort of day 1, we really focused on adding the new conditions. Day 2, which I'm not going to talk about today, but we did spend a lot of time on, was really about communication and how better to facilitate the process. Like how can we better communicate test results to parents and families and pediatricians and everybody. So yeah, so hopefully this gives you a sense of there's a lot to do. And when I see this as somebody who does methods, I see data everywhere, and it's so exciting. I'm still looking at data from this. So there's just endless sources of data. Okay, so I will try to speed it up a little bit because we only have about 20 more minutes. Okay, so this is sort of the specifics of what we actually were voting on in this deliberative event. So at the time, the RUSP recommended, as part of its secondary conditions, sort of these 3 new things to screen for. And they're somewhat controversial. I'm not going to go too much into why each one of them is controversial. They are for their own reasons. And I think you'll see that as in some of the comments. Really briefly, like Pompeii, and again, if, I'm sure Beth could tell you way more details about this, or I'm happy to at some other point if you really care about learning more about each one of these conditions. But Pompeii, I think the big debate there was that there's 2 different types of it. You don't really know which one you're going to have. Like the test isn't great for screening between the differences, and one is like a later onset, one is more severe. So it's just really that sticky for that reason. MPS 1, I think this one is the one where like really the only treatment at the time, which I assume is still true, is that the main treatment is a stem cell transplant, which is like not a easy process, and it's very like unknown how effective that even is. In the state of Iowa, this was even more complicated because I don't think there was even a place that they could do this in the state of Iowa. Like I think the closest place where you could actually do this procedure, which involved part of a stem cell transplant, was like Cincinnati or Chicago. I mean, it was complicated in that sense. XALD is complicated on many levels, but one of the big ones is it's sort of unclear whether or not there's a lot of benefit. There's not really effective treatments for it currently. So should we be adding a condition that doesn't actually have a treatment option? So that's very, 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 very quick overview of all these conditions, and I'd be happy to share with you any more detailed information if you're interested. Okay, so what happened? So we had each one of these, we sort of focused on, we talked about, we had a geneticist come, a pediatrician, we talked about pros and cons of each one of these, and then everyone broke up in their small groups, talked about whether or not we should or should not add this condition. And then what I'm going to show you here is sort of the voting. So for Pompeii, 18 out of 26 people, so that was, about 3/4 voted to add Pompeii disease to the Iowa screening panel. A substantial minority of these people did not endorse this recommendation. And this is a quote from some of the qualitative analysis that I am presenting here to sort of give you a sense of what some of the reasoning was. It's a little bit wordy, but I'll read it to you. I'm usually not an emotional decision maker, but an intellectual decision making. So me, it came down to the treatment that can improve quality of life. So it comes down to this for me. This is a disease, or if you catch it early on, you can maybe have a good life, unlike those other two diseases. So this individual, the way I interpret this is that this individual was saying, yes, maybe we can't tell which type it is, but you have a chance of having a good life, unlike the other two conditions. And I think that what they meant there is sort of like the quality of life. It is not as debatable as the other two conditions. I don't know I'm not here, none of us are here to place judgment on how accurate these comments are, but I think from this individual standpoint, they felt like this Pompeii, you had a chance of having a higher quality of life than maybe if you have one of the other conditions. So that was sort of their rationale for there's a treatment available that may allow that for that. So MPS 1, 18 out of 26 people, about the same amount, believe MPS 1 condition should be added to the newborn screening panel. Again, a pretty substantial minority. I mean, I still think a third is, or a quarter, I guess, somewhere in that range, is substantial enough. I was surprised by that they did not endorse the recommendation. So this is a quote from an individual that said, I mean, the dollar cost. I won't even count the emotional toll on the parent or child or the family. The days of lost work or transportation costs or the hours spent in the doctor's offices. So this was the example where the known treatment at the time was a really expensive, like stem cell transplant, and it's not even clear whether or not it would be effective. And so we talked a lot about how would you even, insurance doesn't usually cover it. I don't know if it, when I say usually, I don't know, that probably translates to does not cover it in most cases. And just getting there would be very difficult for a lot of families, and how would that even be feasible when you have a newborn? So that was really, I think, one of the things that came up a lot with this condition. XALD, 13 out of 26 people, so half of them believe, oh wait, I don't know what I wrote there. I think I just copied the wrong thing. So about half of them did not endorse the condition being added to the newborn screening panel. I think I should have had XLDA, but I put Pompeii there, sorry about that. Should not be added. So this was the only one where they recommended, that this should not be added. It's the same as the other two, is that we could test for it and then we would know, but if the current guidelines, it shouldn't fall under a newborn screening because it's not going to present itself as a newborn. It shouldn't be considered a newborn screening if it's a late onset. So in this example, what the individual is saying is this was the one case where you don't see symptoms, like, so the clinical features do not present in the newborn phase. It actually happens later. We call this later onset, but it's really newborn versus infantile. Like, that's kind of the separation that the pediatricians refer to it as. And so it's something that shows up later. And so this came up a lot in the discussion. People felt like if you could catch it later, it doesn't belong in the newborn screening, as part of the newborn screening process. So some of the takeaways, actually, I think I am, okay. Yes, okay. So some of the takeaways here. Participants felt like what they thought personally didn't equate how they viewed the policy. So that came up a lot, and I thought that was a really interesting point, that you can feel, so we had a family come that had one of these conditions and talk about their experience with it. And it's one of these sort of amazing, amazing cases where the boy is, or not a boy, I guess he's a man now. I think he's like in his 20s, early 20s, going to college, and he's had a fairly, I mean, by any measure, not just, you know, in this context, very successful life, and is doing really well. And his parents, I mean, it was a very moving presentation for screening, for newborn screening, and really, you know, showing that you can literally save a life by screening and adding this super, super rare condition that might have, you know, very few people that have it, and it's a later onset condition, all these sorts of things. Like it was a really good case for that. And what I was very surprised by, so I was concerned that this might be a challenge in the sense that people would be very swayed by seeing somebody who had benefited from the newborn screening program. I was really surprised to hear people talk about the fact that they were personally moved by it, but they were able to separate that from how they actually voted and whether or not it should be added to the panel. So I thought that was really interesting that people were aware of that. Essentially what I'm saying is that I was not giving citizens of Iowa enough credit. They got it, right? They got the fact that this person, this family had been through a lot and they had benefited from newborn screening, but that was not the only thing that they needed to consider. What came up a lot also was that screening should be based on availability and effectiveness of treatment. So I think that was evident in some of the quotes that I was talking about there, that sort of identifying the disease was seen as a minor benefit. So just saying, oh, you have this condition is a secondary benefit, a minor benefit. The main one was whether or not there was screening available and whether or not the treatments were effective. So that was really what they felt like the criteria for it should be, which is one of the criteria for the RUSP. But they felt like it should be more adhered to more strongly. And that was the way that they thought about adding conditions. And the other big thing was screening for newborns versus, again, we call these late onset conditions, but they really were like, they appear within the first 6 months of life. So it's infantile, I think, is probably the better way to think about late onset in this context. There was also a lot of discussion about concerns about the ability of the pediatricians to interpret and communicate the amount of genetic information that might, and the data that might get passed back. Again, that's really, we focused on that a lot on the second day, but I just wanted to bring that up, that there was a lot of concern about that. This is also a terrible, hard to read slide, but I think what I would like you to focus on is the color here and the color change. And really so blue is strongly agree, green is agree, orange disagree, and then, you know, red is strongly disagree. So for example, I think these first two, maybe even three are the strongest examples, but the first one is, this is from the survey that we gave individuals. This was the first time point baseline right after the deliberation. This is then after they went home and 1 month follow-up. I don't know why none of my labels are on here, probably because I was putting this together at midnight. I think newborn screening should screen for conditions even if there may not be life-improving treatment. So you can kind of see that it was, you know, about split 50-50 here at baseline. So this was before the deliberative event. After the deliberative event, you can see a lot more movement in this sort of neutral to disagree area. It's still about 50-50. So I think these people that agreed still agreed. But I think where you see a lot of the movement really is in this, people that are starting to disagree more. So they should, essentially what they're saying is you should not screen for conditions if there's not a life screening treatment. You should only screen if there is one. And the second one is, you know, similar, but it's like if the treatment is expensive and not covered by insurance, there's a lot more movement and towards this disagreeing with that. So you should not screen for conditions if treatment is really expensive and not covered by insurance. So I think that's sort of like what I wanted to show you, is where we saw the movement here really was towards this end, where people started to consider more, and this came up a lot in the debate, whether or not we should be adding treatment or conditions, screening for conditions that did not have treatments available and that were not effective and that were costly. I like this slide because it makes me feel like they did actually learn something from the day. So purple here is very much, so it's sort of like, did you learn anything, or what, my opinions about what is, down here changed at the event. So I think, people learned stuff. That's really good, I guess. A lot of people felt like their opinions about newborn screening changed. Genetics changed, public health service, other people in Iowa. I think I'm glad that people's opinions changed. I think that's that's good. And information without bias. So I think that they overall had a pretty positive experience and felt like they did learn a lot during the day, and that not that they just learned a lot, but it actually influenced their opinions. And this data is from the last survey, so the 1 month follow-up. I forget why I put that slide there. I guess that's because that's the end of it. So I will. What time is it? Oh yeah, we have like 2 minutes. Okay, so these are the some of the very, some of the many amazing people that worked on this project. But Kimberly Piper works at the Iowa Department of Public Health and is in charge of the newborn screening program, and is a wonderful individual and amazing person to work with. Sarah Van Corp was the administrator that helped, or she was the wedding planner coordinator for this project. She did so much work. Julie Harris is at UCSF, was at UCSF, and she was helping with planning the deliberation and deliberative methods. Yvonne Geller did amazing work with all the qualitative analysis. This project was sponsored by the New Steps program, which is part of does a lot of the newborn screening for the Association of Public Health Laboratories. And I would be remiss if I did not thank the Iowa citizens who participated. So any questions? This is an actual photo from a walk that I took near my house in Colorado. So come visit. Okay, any questions? Sorry, we have like 2 minutes.
There's one in the chat box.
Okay. Let me see. Can't see the chat.
I can read it to you.
Maybe I do.
You see it at the bottom? Yeah, click the Zoom.
Oh, is this not? Okay. Oh, what am I doing here? Do you want to just read it to me? That's probably.
Yeah, I can read you. It says from Eileen. Was part of and you can unmute Eileen too. Was part of the education attending to the health economics of each screen? Basis about health economics. Did you include the cost benefit info about each test? Did you include an economic expert on the panel? And how did you just separate the personal from the cost benefit? You could say that most of what is identified early could also be identified later, so why omit or include if timing was the key consideration?
Yeah, so we did, part of the education was health economics. I have a guest. I have a guest here. This is my daughter, Naomi, who was screened in Michigan, not in Iowa.
I realized that I'm wearing Iowa. I did it by
I thought you did that on purpose.
You were talking about Iowa. Yes,
I thought you did that on purpose.
I mean, yes, it was purposeful.
Yes, it was I liked it. So we did not have a health economics expert on the panel. What we did is we provided an expert testimony. They received videos beforehand. There was sort of a website where they could go watch videos. So we probably had maybe 5 or 6 experts on the day of, but we felt like we needed a lot more experts in other areas. So we did about 10 video presentations that people could watch, and they could also listen to it. So we had it just read, and then we had booklets with like the transcripts essentially of the the expert panelists. So we did have a health economist as in that part. We did include the cost benefit information for each of the tests in that part, as well as, and I would say it was oversimplified. A lot of it is just very difficult to assess because it's so rare. But I think what's clear is cost is very high for most of them in terms of financial cost.
I was going to say, from the cost perspective, to give the audience some understanding of the limited, not that it can't be known, but the limits of the field, not economics, but newborn screening, is that there was a committee for, I think they called it resources because we couldn't call it money or something for the feds, for the ACT-UNC. And literally, I don't want to say they disbanded, but literally they didn't have much of the work. There were no qualies, and there was very little true cost or gross cost data post-treatment. So what everyone has done historically has been like, oh, they gravitate towards what they can cost out, and what they can cost out is always itemized. So should anyone want to pursue this, or anyone have a postdoc or PhD student, Dr. Prosser has one working on it, because like the field's wide open, you could make your entire career on it. Yeah. So it's hard to have a cost-benefit analysis when literally the leaders can't even begin to have the discussion at the federal level because there's no.
Yeah. I think what was, we did get a sense of it too when we had the individual, sorry, I need to finish this, okay, thank you. I know, she loves me so much.
Mine's been my part. Go on.
They only love you when you're like trying to do something.
When someone else loves you.
And my husband is supposed to be watching you.
Someone snuck out.
Yeah, anyway. Okay, so I would say it was clear, it came up a lot in the discussion when we had the family and the individual that actually had one of the newborn screening conditions. He was one of the first to be screened. He has this very compelling story where he's like one of the first like 3 children that received, this treatment, and then back in 1980 or something, whatever, 20 something minus today. Oh, anyway, you get the point. So they talked a lot about how much it has cost their family financially. I mean, just, he's wheelchair bound. He has a lot of, special equipment. And so I really think that was when a lot of people got the,
that's when they started to think, oh my God, how much it takes for the family.
Exactly. So I think that's,
We forget the country as a whole does not have a robust wraparound system for those with chronic illness.
Correct.
Either pediatric or not. We think the healthcare system is complete and you get payment, but there's a lot of holes.
Correct. And they were really clear about that, and how insurance paid for little to nothing. I mean, I think he has to have, I can't even remember exactly everything it was, but like his dorm room at college is like set up as like a small clinic basically, because he has to have treatments every day. And so it's, so I think it was very clear. I'm trying to think what else were the.
I think you got it. It was about
personal cost from, personal from the cost benefit decision making. Yeah. I mean, I think that we talked about it more in the second day that I'm not presenting now.
And I would also point out at the federal level, there is no discussion of costs. Zero, as in the absence of.
Yeah. And that was a major concern for people.
It's not the case at the state level where it needs to be executed. It is the situation at the federal level where the guidelines and recommendations are made. So there's a bit of a disconnect.
And, I think maybe this is an overstatement too, but it's sort of left up to the states to figure that part out or decide.
Correct.
So that was certainly part of the reasoning why Iowa wanted to do this.
Well, that was great. Of course, I'm biased because it's newborn screening.
Yeah.
And as I say to those in the audience, as you can see, the field is full of holes. Should anyone be interested in any of this work, there's much to be done and many dollars to be had to do it. And so if anyone has any questions, I think we have your contact info. If not, I can share it in working with Dr. Gornick and or having any follow-up questions. I want to say thank you, Dr. Gornick.
Thank you
for coming to our COVID rescue on our weekly series.
And I'm happy to do a part 2 if anyone wants to hear about the communication or another talk. You can.
Oh, we could do the lab tests. Those were good ones.
Yeah.
So, I might pick you up on that.
Okay.
Well,
here.
Thank you everyone for participating. I'll let you go virtually to your next meetings. And so long to the crew in Colorado from the galaxy far, far away.